Welcome everyone to today's webinar, Reducing Infection Risk, the Role of Single Patient Use ECG in California Hospitals. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. First, we'll begin today's webinar with the presentation and have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be made available after the event. You can use the same link you used to log into today's webinar to access that recording. And finally, if at any time you don't see your slides moving or you have trouble with the audio, try refreshing your browser. You can also submit any technical questions into that same Q&A box. We are here to help. With that, I am pleased to welcome today's speaker. Carly Campos is a registered nurse certified by the American Association of Critical Care Nurses as a progressive care expert. After obtaining her BSN from California Baptist University in 2014, Carly has gone on to serve her local community hospital. In her current role as a bedside telemetry RN, Carly provides care to acutely ill patients. In her 6-year tenure, Carly has exemplified a unique passion for education and research. As a member of her hospital's professional practice committee, Carly actively participates in unit-based process improvement projects to advance efficiency, patient safety, and quality care. Carly, thank you so much for being here today. I will now turn the floor over to you.
Hello and welcome everyone. I am so excited and honored to host this amazing webinar. We have some really interesting data to share, and later on I will review my personal experience implementing Kendall disposable leads in my hospital. My goal is to provide a very high-level roadmap for those of you who are inspired to implement a process improvement change in your facility. With that being said, I am proud to introduce the webinar on reducing infection risk, the role of single patient use ECG in California hospitals. Once again, my name is Carly Campos, and I am a bedside telemetry nurse at a small community hospital in Southern California. In the latter portion of the webinar, I will go into greater detail regarding my professional background and experience. The learning objectives for today are the clinical and economic impacts of HAI, or healthcare-associated infection, on critical care patients, pathogens and contamination rates associated with reusable ECG leads, and finally, evidence supporting HAI reduction associated with single patient use ECG leads. Our focus for today is the role of single patient use ECG leads and lead wires in reducing infection risk, specifically among healthcare-associated infections in California. Healthcare-associated infections, or HAIs, are defined by the Centers for Disease Control as infections that patients get while receiving treatment for medical or surgical conditions. Though HAIs are most strongly associated with the hospital setting, an HAI may occur in any care setting. This includes surgical centers, ambulatory clinics, and long-term care facilities such as nursing homes and rehabilitation facilities. After doing the background research on national HAI trends for this talk, I'd say the most common sentiment around HAI prevention in the US is that we've made great progress, but there is definitely work to be done. The 2019 HAI Progress Report, most recently published by the CDC, estimated that about 1 in 31 hospitalized patients is diagnosed with an HAI each day. This means around 1.17 million patients in the United States are diagnosed with an HAI annually. To give some context, in 2011, 1 in 24 hospitalized patients were diagnosed with an HAI. So there has been clear improvement along many fronts, but this level of avoidable harm is not sustainable clinically or economically. HAIs result in approximately 1 million additional inpatient days and about 90,000 deaths. In reviewing the economic impact on a national level, healthcare-associated infections have an estimated economic burden of $28 to $45 billion annually, $3.3 billion of which are attributed to SSI, or surgical site infection, alone. Taking a more detailed look at the underlying etiology of HAI can give us a hint about where we might find additional opportunities to reduce HAI risk. According to the 2019 National and State HAI Progress Report published by the CDC, hospital onset C. diff infections decreased by 18%. CAUTI, or catheter-associated UTI, decreased by 8%, and CLABSI, central line-associated bloodstream infection, decreased by 7%. As you can see from the chart above, there was no significant change in SSI, or surgical site infection. I find stalled improvement among SSI nationally particularly disturbing because the mortality rate in this population is about 3%. 75% of SSI-related deaths are directly attributed to the SSI, meaning that these patients would not have died if they had not acquired the infection during the course of their care. So what can we do reasonably to avoid SSI, especially among the critically ill? Well, the answer is to limit exposure to pathogens as much as we can. As bedside nurses and providers, we do that through hand washing, universal precautions, rigorous cleaning protocols, and through sterile procedures. We can also be more thoughtful when using medical devices that we know are associated with infection. The CDC 2019 National HAI Progress Report found a 3% decrease in central line device utilization and 7% decrease in urinary catheter utilization. This aligns with the decrease in CAUTI and CLABSI I shared on the previous slide. However, as a telemetry nurse, I don't believe the best approach to reducing SSI in my practice is to be thoughtful about which patients might go without an ECG. This is because oftentimes our patients are so critical that telemetry is not optional. It is essential to the plan of care. Instead, I was inspired to reduce pathogen exposure by driving the adoption of single patient use ECG leads and lead wires. I'd like to pause now for a quick poll. So which ECG lead and lead wire system do you use today? Reusable cables and lead wires, Kendall DL single patient use, 3M single patient use, excuse my pronunciation, Philips single patient use, or Kerbel single patient use? I'll give everybody a few seconds here to answer. Okay, moving forward to our answers here. So it looks like most of you do use reusable cables and lead wires. This is really exciting because you're going to hear a lot of really interesting information. So moving forward into our clinical evidence, the first step in evaluating whether single patient use lead wires could impact SSI rates is to determine whether reusable lead wires are actually a significant source of contamination. Several published studies have found pathogenic microorganism contamination on cleaned, quote-unquote, ready-to-use lead wires. However, these studies did not seek to compare contamination levels with disposable ECG leads and lead wires. Nancy Addison and colleagues did explore this question when they conducted a prospective randomized trial on a convenient sample size of 51 pediatric cardiology patients over a 5-month period. These patients were randomized based on their chart numbers. 30 patients received disposable ECG lead wires, specifically the GE Neotrode 2, and 21 patients received reusable lead wires. All lead wires were cleaned twice daily with an antiseptic wipe according to standard protocol. ATP testing, a validated method for measuring hospital cleanliness, was conducted 24, 48, and 72 hours postoperatively. The lead wire ATP count was significantly lower on postoperative day 1 and remained lower on days 2 and 3. Though the difference diminished over time, it appears that microorganism exposure was reduced during the postoperative period when patients are most likely to be vulnerable to SSI. The chart above depicts the disparity between the disposable and non-disposable lead wires in relation to ATP levels. The next consideration is whether the reduced contamination observed on single-use ECG leads translates into an actual reduction in SSI at the population level. In 2018, Julie Lankowitz and colleagues published a case control retrospective analysis of facility-level SSI incidence for coronary artery bypass graft or CABG surgeries. They used the Medicare inpatient and outpatient limited data set 100% standard analytic files for this analysis. They were able to match 42 facilities that adopted a single patient use ECG cable and lead wire system, specifically Kendall DL, to 274 similar facilities that had not adopted the system. A total of 27,296 CABG procedures were included in this analysis. Single-use facilities performed 1,450 procedures, and reusable facilities performed 22,846 procedures. Cumulative SSI incidence was observed during the index admission until 90 days post-procedure and then compared for the two groups. As you can see from the chart above, there was a significant reduction in suspected SSI at 90 days. To expand on those outcomes, I partnered with Cardinal Health to conduct a new retrospective study of SSI incidence in California hospitals. We were interested in exploring a few clinical ideas that were not covered in the 2018 study I just shared. First, I wanted to see if the relationship with SSI held true, specifically in California. There is obvious value in monitoring national trends, but what works well on an average across multiple states with different populations may not be effective where I practice and for the patients in my care. Second, I wanted to see whether there were any variations in infection type. We analyzed the surgical site infections for operative procedures in California hospitals data set. This is available through the California Health and Human Services Open Data Portal from 2013 to, we identified 33 hospitals that used Kendall DL at some point during 2013 through 2019. Though not clinically proven, it is likely that ECG leads mainly contribute to SSI through direct contact. This means that contaminated leads touch the surgical site and transfer pathogens. Therefore, when single-use leads and lead wires are introduced to a unit, one would expect to see a more pronounced impact on SSI rates for cardiovascular surgery as compared to procedures where lead wires are less likely to come in direct contact with the surgical site. We did observe this pattern in California hospitals. Sites that implemented KDL showed a sustained reduction over time among CABG and cardiac surgeries as compared to small bowel surgery or exploratory laparotomy. Likewise, ECG leads are more likely to influence SSI rates for VRE and MRSA as compared to CLABSI or C. diff. The charts above demonstrate this observation. One weakness of a retrospective study is that you cannot account for confounding variables. For example, hospitals that invest in single patient use ECG leads and lead wires are also likely to invest in other HAI reduction strategies at the same time. Therefore, as you consider the evidence in support of adopting a single-use ECG system, think about what success looks like in your practice and in your facility, and plan to evaluate around those criteria. We will now take a look at an economic evaluation. So it is likely that one key measure of success will be related to cost. An economic model that applied the SSI reduction observed in the Medicare data set I presented earlier found a $450 savings in 40-year per patient costs. This was significant and largely driven by a reduction in length of stay. This same model predicted a $40 million annual cost savings. On a national scale, there is good evidence that switching to single patient use ECG is cost effective. However, that may not be the most compelling explanation for leaders in your facility who are concerned about more immediate return on investment. To close, I'd like to share my personal experience implementing Kendall DL in a community hospital setting. But before we move on, another quick poll. So after reviewing the clinical and economic evidence, how do you feel about single patient use ECG systems? My facility already uses a single patient ECG system and I've always liked it. My facility already uses a single patient ECG, but now I am more comfortable and excited. My facility doesn't use single patient ECG, but now I'm interested in trying. Or great job presenting the evidence, but I'm still not convinced single patient ECG is worth it. So most of you answered my facility doesn't use single patient ECG, but now I'm interested in trying. Moving forward, I would like to share my professional clinical background. So I am a registered nurse. I do have my bachelor's. I am progressive care certified and also certified in advanced cardiovascular life support. I have about 6 years clinical experience in the critical care setting. I am ICU cross-trained. I am an RN preceptor for both the new grad and experienced RN. I am a nurse mentor, which I will explain in just a moment. And I am part of our unit's professional practice committee, which is a very active, hardworking committee. We meet monthly to set goals and implement positive changes. So to give some context about the clinical environment that I work in, I do work on a telemetry floor, step-down unit. A lot of our patients are 3-to-1 critical nurse-patient ratio. This is usually our mechanically ventilated patient via tracheostomy. We also manage BiPAP and high flow in the acute respiratory phase. Some of our patients do receive enteral and parenteral nutrition, advanced IV antibiotic therapy. A lot of our patients are subject to invasive medical devices such as Foley catheters, central venous catheters, hemodialysis catheters, and gastrostomy tubes. We do administer advanced continuous infusions such as insulin, cardizem, amiodarone, dopamine, heparin, 3% hypertonic saline, and Lasix. In the acute phase, we do treat COVID-19, sepsis, DKA, GI bleed, acute respiratory failure, pulmonary embolism, and atrial fibrillation. Some chronic disease that we encounter are heart failure, hypertension, COPD, diabetes, stroke, and end-stage renal disease. I think it is extremely important to paint a very vivid picture of how critical and vulnerable the patients that I work with are. This realization of the inherent vulnerability of the critical patient is really the driving force for my inspiration for change in my hospital. Most of these patients are bedbound and nonverbal, so they truly do not have a voice and rely on the bedside nurse to be that first line of defense for them. They have impaired nutrition, they are immunocompromised, they have impaired skin integrity, and most of them suffer to some degree of some psychosocial compromise, and this really acts as a barrier to healing. In moving through this process, I had to evaluate our current practice. So although we do clean our telemetry leads and lead wires between patient use, there is no standardized sterilization process. So there's no way for us to trace or surveillance the effectiveness of these cleanings. For those of you who are familiar with telemetry leads and lead wires, the composition is very intricate, and this really acts as a reservoir for pathogens such as C. diff, VRE, and MRSA. These wires are very difficult to clean. We also took a look at the anatomical positioning of the lead wires. They are positioned on the anterior chest and trunk. So although my hospital does not perform cardiothoracic surgery, the ECG leads and lead wires are in close proximity to other incisions and medical devices such as chest tubes, central lines, new pacemakers, portacaths, G-tubes, or hemodialysis catheters. There is an undeniable risk for cross-contamination between the device and the patient. We also took a look at evidence-based practice. So as we reviewed earlier, there is a proven association between HAI and reusable lead wires. So just because we've used these devices for decades doesn't mean that they are the safest device or technology for the patient. We truly have to consider the literature and the evidence in our decision-making. I also wanted to make sure that we were adhering to national patient safety goals set forth by the Joint Commission. There are a number of them, but one top priority is reducing HAI. I also wanted to work towards reducing technology hazard related to clinical alarm fatigue, and ultimately improve public health. So these patients are eventually going to be discharged back out into the community, whether it's to a different facility or home. And if we can control or minimize the transmission of resistant bacteria, we can truly help improve community health. Taking a deeper look into my implementation journey, my journey actually began as a leadership project to apply for Nurse Mentor, which is the pinnacle of the clinical ladder system at my hospital. Fortunately, I am blessed to work with an amazing manager who is willing to help guide me in this process. As we were reviewing potential projects, she told me we had about a week's supply of KDL samples. From there, I designed and oversaw a trial study to see if implementing KDL permanently was something we should work towards. I also collaborated with the KDL representative who was so amazing and supportive. We provided clinical education on the new product to all of our staff. This included application and troubleshooting. And ultimately, we executed the one-week trial of the Kendall product on all existing and newly admitted telemetry patients. This was a one-week trial back in October of 2019, so quite some time ago. In advocating for this process improvement change, I put together a brief but concise PowerPoint presentation covering a literature review on HAI and clinical alarm fatigue. The PowerPoint also covered an observed reduction in false clinical alarms on our unit during that one-week trial. I also performed a staff satisfaction survey pre- and post-implementation. In that survey, I found that most of our staff were truly dissatisfied with the reusable leads in regards to troubleshooting and false alarms. I had to endorse this benefit of change to my nurse manager, director, and ultimately our CNO via chain of command. I attended informal and formal committee meetings with members of the multidisciplinary team and administration. I attended meetings with materials management to discuss cost and feasibility. I presented this benefit of change at ICU and telemetry staff meetings, including RNs, CNAs, and monitor technicians. I think it is extremely important to include all members of the team, as each of us are affected differently. And finally, I had to practice a lot of patience in awaiting the final adoption of change. So we did not have a hospital-wide rollout of the Kendall DL products until about January of 2021. In measuring success, we have seen a reduced number of clinical alarms. This is mostly on behalf of the monitor technicians. And we have seen an enhanced compatibility amongst monitoring devices. So for those of you who are familiar with the KDL products, there is a pink adapter attached, which makes transitioning between devices very seamless. For example, switching from an overhead monitor to a mobile telemetry box, or transporting a patient to surgery or radiology, or hooking up a patient to a defibrillator during a code. It truly is as simple as one click. I spent the latter portion of 2020 working in our COVID ICU, and I can tell you from firsthand experience that every second and minute counts when you're trying to save a life. We also adopted the KDL recycling program in an attempt to be eco-friendly and conscious of our budget. And I think the most exciting thing is that we've opened up the opportunity for future studies comparing incidents of HAI pre and post integration of the KDL products. We're about 6 months into our house-wide integration, and I think now is the perfect time to start gathering and evaluating some very valuable data. I do want to briefly review some barriers to implementation. So this is definitely coming from a bedside nurse perspective. There's probably going to be some component of fear and intimidation. You know, where do I begin? What am I passionate about? What is feasible or realistic? There may be some complacency. As a bedside nurse, I know it's very easy to get stuck in the monotony of, you know, clock in, clock out, patient care, medication pass, and charting. But I really encourage you to break through those barriers and become a part of something that's much greater. There may be a perceived lack of support and guidance. If you're struggling with where to turn, who to turn to, I suggest maybe starting with a committee or seeking guidance from your clinical educator or manager. This definitely takes building a rapport with them and expressing your interest and willingness to participate. It really takes you putting yourself out there. Economics are definitely a barrier to implementation. So I come from a very small community hospital where we definitely strive to be as lean and budget conscious as possible. So this is quite a big undertaking for us. I had to address the fact that while this was not a direct lean process, the indirect long-term cost savings were far greater. And then finally, timing and delay. So we were coincidentally trying to do this house-wide rollout of this new process change during COVID. And a lot of our time, money, and attention were obviously spent elsewhere. So it's extremely important to exercise both patience and perseverance in keeping that end goal in mind. Finally, I'll close with just some beneficial outcomes. So first and foremost is going to be patient advocacy and safety. As I mentioned earlier, our critical care patients are extremely vulnerable and truly have no voice. We are that first line of defense for them. It's very special to be a part of nurse-driven change. In implementing something at the unit level, it could expand to the hospital, so that was really exciting for us as well. You'll also be compliant, as I mentioned previously, with national patient safety goals and also other organizational goals. There will be a long-term cost savings in relationship to reduced HAI, reduced length of stay, reduced readmission, and improved patient flow. You have the potential to inspire peers and future projects. You will be adhering to evidence-based practices. And finally, professional accolades. So I put this last because I don't believe that it should be the driving force for change. However, I don't want to undermine how incredibly special and humbling it is to be a part of something greater than yourself. Through this journey, I was actually able to apply for Nurse Mentor, and I am now part of a very small, coveted group of nurses who have proven their dedication to clinical excellence, education and research, community health, and mentorship. But most importantly, through this process, I was provided the opportunity to speak to all of you today. And for that, I am extremely grateful. I am a true testament that your voice does matter and you can bring about positive change. So thank you all for listening. I hope you enjoyed the information presented. I would now like to turn it over to Molly, our moderator, for questions and open discussion.
Terrific. Thank you, Carly, for such a great presentation today. Attendees, we will now begin today's question and answer session. So you can submit any questions you have by typing them into that Q&A chat box you see on your webinar console. We have had some great questions roll in already, so thank you for those, and please keep them coming as you see fit. But Carly, just a piece of feedback to start off with, we had a note passed through. It says, "Great job, Carly. You make me excited to reevaluate how we manage the ECG cables at our hospitals. Patients and nurses are in good hands with you as their advocate." So with that in mind, the first question I would love to pose from an attendee is, could you tell us more about the rationale behind the hospital-wide adoption of single patient use ECG leads? And specifically, how did nursing preference regarding ease of use and fewer false alarms, like you mentioned, play into the decision to adopt the entire facility?
So we definitely started, as I mentioned, at the unit level, and it was just a simple one-week trial, and we got so much positive feedback from the telemetry staff and the ICU staff that we really championed for this house-wide change. I think one of the biggest driving factors is definitely compatibility among the units. So we are now able to easily transfer the patients from the emergency department to the telemetry floors. So there is no delay now in transferring over that telemetry information or even hooking them up to the monitors. And there has been a significant reduction in clinical alarms. I think that the device itself is a lot more secure than what we were using in the past. So yeah, just definitely a lot of positive feedback from our staff.
A couple questions came in specific to cost and investment, which you had mentioned, Carly. The first is, what advice do you have for other nurses when it comes to discussing the cost difference when switching to single patient use ECG systems? So you mentioned some systems or hospitals, they may want to see a more immediate ROI. So how did you approach those conversations? And then second, do you feel the investment in single patient use ECGs has been worth it?
So I would definitely say that cost is probably one of the most intimidating barriers to overcome, especially coming from a bedside nurse. You know, trying to convince upper management that they need to spend more money is always going to be a hurdle. But I really had to tie it back to the global objective of reducing HAI and the billion-dollar amount that's attached to that annually. So like I mentioned, you're not going to see an immediate return, but long-term, there will be cost savings. But it is one of those things you have to overcome. I would just recommend being very prepared and really relying on the evidence to speak for you, the literature and the evidence, and presenting it in a very clear, concise manner so that it's something that people will consider.
Terrific. Thank you for your guidance. Let's see. Some people, as we saw through the poll, they already do have single-use ECG leads and lead wires in play at their organizations. They're curious, how are you continuing to measure the success? What metrics are you keeping an eye on? How are you monitoring the efficacy?
So as I mentioned, we're about 6 months into this house-wide rollout. We have not gathered any hard quantitative data yet, but I think that, like I said, this is a perfect time to start gathering that data and evaluating the numbers related to HAI, cost savings, and clinical alarms. So unfortunately, we haven't done any hard data trials or evidence review, but that is something that we can work towards in the future. For now, it's truly kind of just a verbal report of staff satisfaction in regards to reduced clinical alarms. Okay.
And on that note, Carly, another question came in related to alarm fatigue. Can you talk a little bit about what you've seen in terms of a difference, an increase, decrease in alarms with the KDL leads?
Yes, so the system itself is a lot more secure than what we were using. So we have seen a reduced incidence of lead pop-off or interference or artifacts, and that has been a huge help. Alarm fatigue is such a huge problem, especially on a telemetry unit, and it extends beyond the nurse. It really affects CNAs because they're being pulled from their jobs to troubleshoot these devices. Monitor technicians, bless their soul, they sit there for 12 hours and listen to these alarms. So we have seen just a more efficient system, a more secure system, and a reduction in the clinical alarms. And this is really, really important because right now, more than ever, our time needs to be spent appropriately. So if we're being pulled from our tasks to troubleshoot or respond to artifacts that isn't true, it really does impede patient care.
Okay. Thanks, Carly, and thanks, attendees, for your questions that have come in so far. This next question, Carly, an attendee would like to know, did your emergency department also adopt the disposable leads, and would there be, if they did, would there be a significantly higher burn rate in the ED?
I do believe that our emergency department has adopted the system, but I would have to double verify with management. I do believe that these lead wires also get transferred with the patient from the first introduction. So they stay with the patient throughout their admission, and so it's a one-time use. So yes, I do believe that we adopted them in the emergency department.
Okay. And you were anticipating attendees' questions beautifully. This next question was about whether when you transfer patients from the ICU to telemetry, does their single-use cable travel with them, or do you grab a new one? So it sounds like it stays with them.
Yes, definitely. We do want to be as cost efficient as possible, and we also recycle our leads.
Okay. Well, Carly, that is it for the attendee questions. I want to thank you for such an excellent presentation today, and Cardinal Health for sponsoring today's webinar. To learn more about the content that was presented today, please check out that resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and on behalf of Becker's, we hope you have a wonderful afternoon.